Well, thank you for having me. I'm really excited to talk about this topic. And as I mentioned, it's definitely not exhaustive, and some of it has data, some of it doesn't. But feel free. I think, is it okay if we do a forum where people can ask questions as we go along, or would you rather people save it till the end?
I think that's fine. If people have questions you feel like you can't say them, you can always write them in the chat.
All right, terrific. Well, I'll get started. So here's some of the topics I'm going to highlight, and that is in the topic of the importance of women's health and CF. I think the key thing to remember is that people with CF very excitingly are living longer and healthier lives. As a result, a lot of topics that I think we didn't address in CF in the past are really critical to address now. Some of these include a difference that exists in overall outcomes between men and women, and what we can learn from this in order to bridge this gap and narrow it and make everyone do equally well. The second is talking a little bit about puberty, the timing of that in CF, and what we may know about how that impacts health. Then moving in a large bulk of this into the reproductive years and what we know about cyclical variations in health of women with CF, what we know about hormone contraception, and then some of the challenges and complications that women with CF face in terms of fertility and pregnancy. And then finally, moving into some topics we may not have nearly as much data on as we would like, and that is menopause, the timing of this, the role of hormone replacement therapy, even osteoporosis, and the outcomes of women post-lung transplantation. All right, so I'm just going to get started and begin by some of the literature we have on outcome differences between men and women with CF. So first of all, the prevalence, or the rate at which males and females acquire CF, is identical, because most of you know this is what's called an autosomal recessive genetic inherited disease that is not linked at all to the sex chromosomes. Men and women obtain this disease at an equal rate. However, the outcomes in men and women are very different, and this was first described back in the late 1980s, in which it was described that women did not do as well as men. And actually, this got confirmed using big data registries across the United States, Canada, and England. And as therapies have improved and people are doing much better, of course, everyone's living longer, which we're thrilled about, but this gap between men and women still exists. And when you look at some of this data, this was one of the first reports that came out in the late 1990s, and this was from data using the CF Foundation's patient registry database. And this is a United States database that looked at data from 1988 to 1992. And there was over 21,000 people included in this analysis. And they looked at overall survival between men and women, just long-term survival. And keep in mind when you see these numbers, this data is from decades ago. So that was when people were not living quite as long. But this is just what we call over here, this graph on the right is what's called a Kaplan-Meier plot, where it just looks at survival by age. And this also, keep in mind that this is median survival. And I know people talk about survival a lot in CF, and I think looking at some of the numbers is always, I think not accurate across everybody. What median means is this is the middle number. So there's going to be many, many people that do way better than this, and unfortunately some people that don't do as well as this. But this is just the middle number across men and women. And when you look at this plot at this time, men were living to the age of about 28 and a half, and women really to about 25 and a half. And this data actually they did a very thorough analysis trying to control for a variety of different factors that may influence health at that time, including people's nutritional status, the age of which they were diagnosed, what their lung function tracked with in terms of this, different things about race, and even different bacteria they grew. And despite this, it really still came out that for reasons unknown, women were not doing as well. There was a lot of thought that as people started to get better and better and the medications improved, that this gap had narrowed. However, another group looked at this data later in a data set, again, from the United States Patient Registry, that looked at patients between 1995 and 2007. So a later cohort, but still not as new as what we have now. And did a very similar analysis where this middle left graph is, again, this Kaplan-Meier plot of survival. And you look at the median life expectancy found here, and it's about 36 in men and 38.7 in, 36 in females and 38.7 in males. And this, again, is looking at a huge group of over 32,000 people in the database. And there was, again, a very detailed analysis done controlling for all sorts of different factors. That also included genotype, it included BMI, it included all sorts of bacteria, it included CF diabetes, and despite all that, when you look over here at this right complex table, this top variable you see here where it says female, and it has this relative hazard ratio of 2.2, that means that anytime you see a number that's greater than 1, that the risk somehow of not living as long is worse in that scenario. So accounting for all these different factors, there's still some disadvantage that women with CF face that we don't understand yet. Interestingly, when they really did some sub-analysis of all of this stuff, and particularly looking very in depth at bacteria prevalence in patients and when they acquire these bacteria, it's very interesting that some of the things that came out were maybe themes that we've seen in the literature before, and one of those being Pseudomonas aeruginosa, where when you look at here on this table, these top 2 lines of Pseudomonas aeruginosa, including the non-mucoid form and the mucoid form of Pseudomonas, and the very top line being men and the bottom line being female in each category, you see that women acquire this bacteria. The mean age of their first culture is younger than the mean age of men. And this actually existed in a number of bacteria, not just Pseudomonas. I think a couple of others very interesting to highlight are other things such as non-tuberculous mycobacterium, which some of you all may have heard of, or things such as MAC or MAI and Mycobacterium abscessus. And these bacteria are really slowly starting to be understood as bacteria that women may be more susceptible to getting, not only at an earlier age, but even once they get it, maybe having a worse response to these infections relative to male counterparts. So this is another manuscript or set of data that highlighted this, where they looked at boys and girls, so starting very young, looked at survival over time, and actually looked at all those who acquired Pseudomonas, breaking people down into those who acquired it at a very early age, less than 6 years of age, and those who acquired it later in life, greater than 6 years of age. And you can see again on this Kaplan-Meier plot, the women are in this dotted line. The women are in this dotted line right here, and the men are in the solid line, and these are the ones that acquired it early, versus over here, the women again in the dotted and the men again in the solid, that particularly the earlier in life, females acquired the Pseudomonas bacteria, the more steep their plot of not doing as well is going to be relative to males. So there's lots of wonder about why that's the case, but now the theme has come out in a couple different times. So then moving a little bit into what does this translate? As you can see that we're going to talk about sex hormones obviously today, and you may already be wondering, well, these phenomenons seem to be occurring even before puberty, so is it all related to sex hormones? And I think the answer is going to be we don't know, and maybe not, but I think there's some evidence that's going to point to the fact that puberty, when sex hormones do start to flourish, is some sort of point in life for people with CF that really separates out men and women a little bit. So this was another set of data where, again, the United States CF Foundation patient registry data was evaluated, really looking at the rate of exacerbations with the red line. So with time 0 here in the middle of this graph being the point of puberty, and looking at the 10 years prior to this point of puberty versus the 10 years after this point of puberty. And the red line here representing the number of exacerbations per year in females versus the blue line, which is number of exacerbations per year in males. And as would be expected, after puberty in general is a time where people with CF experience more exacerbations. As people get older, CF is of course much tougher. And when you look at this rate, despite what we saw about that data on females with Pseudomonas females acquiring Pseudomonas earlier, it really isn't until about 5 or 6 years after puberty that this rate of exacerbation between men and women separate out, where women start to have more exacerbations relative to men. And again, an in-depth analysis was done trying to control for different factors that might be impacting this. But still, regardless, it came out that women have more exacerbations than men after puberty. So this really sets the stage of why is this? I'm sure that's the initial thought that you guys were having, and it's certainly what I was wondering is what is it that's setting this off? And there's been lots of theories, and I'll tell you right off the bat, we don't know the answer, but these are just some of the things that people are evaluating. Some of it is just the mere size of the lungs and or just the airways in women. In general, women are more petite than men. As a result, often the lungs themselves are smaller, and in particular, the airways are smaller. And when the diameter of an airway is smaller in one person than another, and you need that area for mucus to clear, it may or may not predispose someone to not being able to clear out mucus as well, and maybe even having more susceptibility to infection. I think no, but the best surrogate for lung size is actually height. And height got controlled for in a lot of these studies. Now, that doesn't mean it's in some way not impacting it, but it did get evaluated, and despite people's heights being identical, there was still evidence that women weren't doing as well. There's other things such as behavioral aspects that may be influencing things. Could it be an issue where for some reason women are not as adherent to therapies? We certainly don't have any data to suggest this, but this is one thing that has not been easy to control in studies because it's not a very easy thing to pick up in these databases. Could it be physical activity level? I think people wonder that a lot. People wonder if maybe women don't exercise as much as men. I think that may be the circumstance in some cases and certainly not the circumstance in others. So it's hard to again, account for that in some of these studies. And then the other that comes up a lot is mental health, and there's thought to be very early evidence that maybe women have more evidence of depression and anxiety than men. I again don't think that this is clear yet, but there is some thought that could this be affecting people's outcomes, how they behave, or even what we call epigenetics, and that is some sort of secondary phenomenon on the genes and the processing of protein in the body, et cetera. And then comes into comorbidities, and that is to things such as low nutrition or a lower BMI, and even things such as diabetes. Is that impacting women at a worse rate than men? I think there has been in the past some thought that women have a lower nutritional or BMI state than men, but I think that is one that's changing, and two, again, that was accounted for in some of these studies, and even when equalizing that in the databases, we still saw this came out was diabetes, that there has been some evidence already out there in the literature that diabetes may impact women a little bit harder and that they struggle with control a little bit more than men for reasons we don't know. And some people hypothesize that this could be one of the reasons that women are doing worse. But this got accounted for again in some of these studies, and despite that, we still found women doing a little bit worse. And then the final thing, of course, brings us to sex hormones. That's a clear thing that's different between men and women, and whether or not this is the only reason or part of the reason that this is occurring, I think we have some evidence now that this is certainly part of the reason that this disparity is occurring, but I don't think we know yet whether this is the only reason, and it would not surprise me if this is not the only reason. But I'm going to tell you about a little bit of the data we have on how sex hormones are impacting immunity in general, maybe mucociliary clearance, things such as inflammation, and other things such as susceptibility to infection. So I just, before I started, want to give you guys a background a little bit on the main female sex hormones, just in case people are not aware of this, because this is certainly not a topic I knew about that much when I began my interest in this. I think a lot of our obstetrician and gynecologists and family planning experts tend to know a lot more about this field. But in general, the two main female sex hormones are estrogen and progesterone. And as most of you know, they'll vary in levels throughout the ovulatory cycles in women. And if you look at this bottom graph here of what the phases are of where these hormones are in the different parts of the cycle, there's when women are menstruating or having your cycle, the hormones are actually at their lowest level. So the red here represents estrogen and the green progesterone. As the phase of the cycle goes along, the estrogen starts to increase, and that leads to this peak in LH. This is the marker of actual ovulation. And then as time again goes along in the cycle, it's progesterone that starts to rise to the highest in what we call the luteal phase of the cycle. And if you look over here on these two charts of the estrogen levels and the progesterone levels, you can see that there's huge variations of where they are. So in the beginning, for example, in what we call the follicular phase, which is where menses occur, these levels can be as low as 30, which is what we can even see in a male. However, when people, when people are hitting ovulation, they're nearly quadruple, if not more than that, in amount of these hormone levels. And similarly with progesterone, it varies tremendously as the cycle goes. So this is obviously leads to the hypothesis of what do these fluctuations do on health if we think these hormones are affecting people. This is just another graph so you can kind of see what happens when these different hormones are moving. So you can see that what actually occurs in the lining of the uterus is that when you're shedding your lining of your uterus, which is when menses is occurring, is when these hormones are lowest. Then when the actual egg is coming out of the fallopian tubes and you're actually undergoing ovulation where an egg is released is when you get the peak of estrogen, and then the lining of the uterus is building back up as your progesterone level is rising. And this on the bottom right is just we're going to get into very small amounts of science here, but it's just to let you know that both of these hormones, estrogen and progesterone, work by acting on different receptors in the body. So they're this little purple, kind of, I don't know what you call it, like a horseshoe almost looking thing, is they're binding to these different estrogens and progesterones around the body. And these receptors, very importantly, don't just exist in female part, in terms of they don't just exist in gynecologic parts of the body. They don't just exist in the breast tissue. They actually exist in many, many tissues throughout the body. And very importantly, they exist in the lungs, and we know that. So when you have circulating hormones in the body, when it comes to estrogen and progesterone, they have the ability to bind to these receptors all over the body. Okay, so I'm going to move a little bit into what we know about puberty and then move into the reproductive part of people's lives. So we know actually quite little about puberty in CF. I think the data I showed you about the timing of exacerbations may be one piece, and then the other piece comes into what about the timing? Is the timing different in people with CF than it is in people without CF? And the answer in a good way is probably not. So there was a study done looking at the timing of puberty in CF. And this was actually based on a marker, instead of being based on what we call menarche, when women start their cycle, or in anything like a Tanner stage of development. This was using data looking at peak height velocity, which is thought to be, that is when you're most rapidly growing, and is thought to be a great marker of puberty in people. And part of the reason this was used as a marker of puberty is because when you look at national databases in cystic fibrosis, we don't yet have databases that have good information about menarche or Tanner stages or any of that stuff, but we do have great data, excuse me, which is our CF registry, about people's height and how it changes over time. So this was basically looking at people's point of their peak height in men and women over using the National CF Registry. So you can see here that we actually found that in CF for males, this occurred at about 13 years of age, and females, that this occurred at about 11 years of age. And when you look at the general population, the actual mean age of puberty in males is about 13.4, and females is about 11.8. So really not far off from what we found in CF, which is terrific. I'll tell you though, one very important thing to keep in mind is what actually a sub-analysis was done of this, looking at nutritional status with using BMI or body mass index as a surrogate of that. It was noticed that if people were undernourished and their BMI was very low, then they did have big delays in their peak point of puberty. And that's well known even in the general population. But I think this was a very recent data set where as people's nutrition has really been overcome between pancreatic enzymes and good supplements and good vitamins, that people's nutrition overall in this data set was very good. And I think that's why we found that puberty timed out very similar to that of the general population. Okay, so moving a little bit into what we know about the reproductive years and what fluctuations in hormone levels may or may not do to health in CF. And I think people are very interested in this and still very interested in this. So there is just, right up front, there's very little good documentation and literature on this topic. The first paper really out there looking at this that I'm aware of is this one that was published in the early 2000s. And this was a very, very small study of only 12 women with CF. And what they did is they looked at just plain old FEV1, which I think all of you know is that number of what you blow when you're in the clinic. That's a real marker of how your lung health is doing. And they looked at it at the point of luteal phase, which is when I told you that progesterone level is at the highest. And then they looked at it at menses, when the hormones are the lowest. And really found that when you look at this difference over time, that lung function tended to be lower when people were having their cycle. Now, again, this is only 12 patients. It was a small difference, but I will tell you there was a flaw in this study, and that many women in this study were on hormone contraceptive therapy. And when you're on hormone contraceptive therapy, the whole fluctuation in these hormones do not occur. They're much, so it lends itself to wondering why this was, or whether or not we really can trust what this showed, given that many people were on hormone contraception. Were there any questions? I hope I didn't miss any. All right. So then moving into other data that we know, this was actually a much more thorough look at some of this topic. And this was a big paper that came out of a group out of Ireland that was published in a huge medical journal called the New England Journal of Medicine in 2012, so really not that long ago. And what this group did was they took a large number of women from their own center in Ireland and tracked what the estrogen levels were in women's blood when they were having exacerbations. So this graph over here on the left is number of exacerbations and this different in their population of women over time when they're having exacerbation, and in red is what their estrogen levels were. So you can see that in terms of these numbers of exacerbation and days on the cycle, which they tracked here, they found that the highest number of exacerbations in these women tended to occur when they're about 5 to 12 days into their cycle. Now that's actually at that point where people are ovulating, when estrogen level, as you can see here that they found, is the highest. So they really hypothesized that somehow this increase in estrogen was maybe potentially contributing to higher rates of exacerbation in that point in the cycle. They also, on this right graph, looked again at exacerbations, and that is they looked at when people were stable, and they looked at when they were exacerbating, and they measured estrogen levels in the blood in women here in the black who had CF and were not on any oral hormone contraceptive therapy, in this clear white bubble in women with CF who are on hormone contraceptive therapy, and then here in the gray, these in men as a control. And you can see in general that they found that women on hormone contraceptive therapy had an exacerbation rate that was actually lower than women who were not on hormone contraceptive therapy. And that, their hypothesis, again, was basically by being on hormone contraceptive therapy and by minimizing that ovulation spike you'll get with estrogen rising, that somehow this was associated with fewer exacerbations. Now, this was all association, meaning there was not any direct mechanism suggesting this was occurring, but just based on timing and estrogen levels and looking at their center and exacerbations, this is part of what they concluded. They also went on, and this is a pretty busy slide, and I'm just going to walk you through a little bit of this, is they also looked a little bit more in detail at Pseudomonas. And part of the reason they chose Pseudomonas aeruginosa is, as many of you guys may know, this is a very prevalent bacteria in cystic fibrosis. It tends to be associated with people doing not as well once you acquire this bacteria. And there had already been some evidence in the literature, which we talked about, showing that maybe women were more predisposed to Pseudomonas and that when they acquire it, they do as well. So what they actually found, they looked at Pseudomonas and they looked at what's called alginate, which is the production of a material that comes out of Pseudomonas when it's becoming a mucoid form. And they actually found over here that there are different types of estrogen, but they found that both the two most common forms of estrogen, estradiol and estriol, these two forms in these darker blue bars, both increase the prevalence of this production of this alginate, meaning it was somehow associated with more mucoidy formation. And that's visible in these pictures here, where when you look at actual colonies of Pseudomonas in a plate, they found that when you treated the Pseudomonas with estrogen, that it turned into more of a mucoid form, which is marked by this kind of globular look to the Pseudomonas that was not visible when they treated these with testosterone. And then they again went back and looked at their patients. You can see on these right-hand sides, I'm not going to go into all the details, and basically found that more women, particularly in the point where they're at their ovulation point, were in a more mucoid form of Pseudomonas than otherwise. And they hypothesized that because this can sometimes mean a more virulent form of Pseudomonas, not always, but this may be one explanation of why they were seeing people exacerbate more at that point of ovulation where estrogen's the highest. And this is probably one of the biggest studies we have to date looking at anything related to hormone contraceptive therapy and estrogen and how this may impact different markers of health, with the main thing they focused on being exacerbation. So now I'm just going to go a little bit into some of what we've been trying to understand on the mechanisms of why this may be occurring. So this is really a slide that walks through some of the biology of CF and what we're trying to understand on, is there something about estrogen and or progesterone that may be actually impacting, in a way, immunity for women with CF differently than it's impacting men. And so this, if you walk through this, what happens in CF that makes people have these thick secretions, for example, in the lungs, is when you don't have a normal CF channel on the cells of the body. This means that chloride is not coming out of the cells as well. Everywhere in the body chloride goes, sodium goes to balance the charges, and everywhere in the body sodium goes, water goes. And one of the nature of CF is that because chloride is not able to get out of the cell, water is not on the top of the cells, and so mucus tends to be dehydrated. And it's because of this that people get a very, reduced, what we call reduced air surface liquid, meaning that top layer of water is not there. This leads to thickened secretions, and this leads to what we call impaired mucociliary clearance, the inability to get that thick mucus out. And it's really that process that leads people to go through what we call this cycle of getting infections in the lungs, that causing inflammation in the lungs, and that ultimately causing this airway obstruction, which is what leads to FEV1 going down. So it means that this mucus is getting trapped in there, it can't get out of the airways, it's leading to the FEV1 going down, and this sort of leads to lung damage, bronchiectasis, which is the inflammation of the airways of the lungs, and ultimately to the lungs not doing as well. And of course, as we know, it's still really the problems with the lungs that are the main reason that people aren't able to do as well as we want, and what's still, unfortunately, the leading cause of death in CF. So we really are still working very hard to overcome the lung problems, despite the fact that all the other parts of the body still matter. But the same process actually occurs in all the other organs as well, but it's the lungs that we're trying to target first, mostly because of the infection side of it. And this over here really represents these targets that we talked about, the estrogen receptors and the progesterone receptors, and we're trying to figure out, is it the impact of estrogen on these receptors on any different parts of these processes that is somehow leading to women not doing as well? And people are working very hard from a scientific standpoint to try to solve this. So some of this is going to get really technical, and I'm not going to go into the details. So I'm just going to tell you that some of the things people have found, and these are just a few of the references, is that are in general, estrogen in particular, and maybe even testosterone, can actually potentially impact the expression of CFTR in certain cells, and it can potentially impact the expression of the sodium channels on the surface of some of these cells, not only in the airways, but in other parts of the body. But most of this has been found looking at animal models or looking at cells outside the body. So I'm just going to leave it sort of globally that there may be some evidence that these hormones can actually impact CFTR. There's also some evidence, and this was a really nice study done out of a group in North Carolina, where they looked at and showed that estrogen actually can impact chloride channels that aren't CFTR. So just to walk you through this slide a little bit, it's a very technical looking, but this cell here represents the surface of a cell in the lungs of the airways. And the cells, as you guys probably have heard, have these little hair-like cilia on the top of them, which is what you see here. And this would normally represent, in a person without CF, that water layer that I was telling you about, where you need, it looks big, but it's actually very microscopic, this little water layer where people are normally able to breathe in particles, breathe in bacteria, but it's with this water layer and it's with these hairs that we can cough these out. And here, this water layer, as you can see, is really controlled largely by CFTR, which typically moves chloride out. There's a sodium channel here, which balances that chloride with sodium. And as I mentioned, everywhere in the body that sodium goes, water goes. In CF, without the normal CF channel there, you're not letting the chloride out. You're, as a result, getting more sodium trapped inside the cell, more water inside the cell, and then this layer is lower. So there are other chloride channels on this surface that this group actually found that in particular, this other, what we call calcium-mediated chloride channel over here, was getting impacted by estrogen, such that in a setting where in CF you're relying on some of these other chloride channels to help move a little bit water out, that if estrogen is actually inhibiting this other chloride channel, you may be at even more risk for having less water or less hydration of the mucus than even otherwise. And so they hypothesized by estrogen impacting some of these other chloride channels that may be one reason why women with CF get hit even harder from a standpoint than men. And they actually did this in, not only in cells, but actually in a very nice mouse model that I won't go into all the details, but it became another very well quoted piece of literature out there to suggest that there may be something unique to CF women that is being controlled by estrogen. Okay, so I hope I'm not getting too sciencey for everybody, but I think this is, really important on understanding what people are trying to solve on what these different sex hormones may be doing. So this was another article that really looked at CF mice. So these are mice that have been studied where they actually knock out the CF gene in these mice, and particularly in the lungs. Now I'll tell you, the gut is spared the way these mice are developed, because otherwise the mice have a big difficulty living without the nutrition they need in certain techniques. But in general, the CF channel was entirely knocked out of the lungs in these different mice. And when these mice were infected with Pseudomonas aeruginosa, there was just basically on this top left, this is going back to those same Kaplan-Meier curves that you saw in the past, where this is female mice with CF versus male mice with CF that were infected with Pseudomonas. Now these mice were weight matched, they were treated identically, there was nothing different genetically about these mice other than one was a female and one was a male. So as you see, the female mice here in the red graph did not live as long as the male mice with the exact same infection. Then when you take these female mice and you actually remove the ovaries, take the hormones out of these mice so that you're just focusing on these female mice, and then you give them back estrogen, which is here in the red, versus progesterone in the green, versus this blue line where they have no estrogen or progesterone, you actually see that it was found that the estrogen-treated mice did not do as well as the others. So this is kind of one of the, another pointing to the fact that is estrogen somehow doing something a little bad to the immunity of these mice when they're infected with Pseudomonas. These are all mice that got infected with Pseudomonas. And this is I'm going to try to get out of the sciencey part here soon. But then when you look at these mice, again, these were CF female mice here in the red, and these were actually CF female mice that got treated with this little drug called ICI. And what ICI is it's actually an estrogen receptor blocker, meaning when the estrogen receptors were blocked so they wouldn't respond to estrogen, the mice actually did better. So it was, again, something pointing to the fact that estrogen was making the immunity of these mice not as good. And this final graph here on the right is actually something, these are called colony-forming units, which are bacteria remaining in the lungs of mice when they got treated with this Pseudomonas and given different types of hormones. So these are female mice, one group with no hormones, one group with only estrogen, and one group with progesterone. And it showed that the ones with estrogen had more Pseudomonas left stuck in the lungs than the others. The others started to clear the bacteria, which is the natural response of any person, any animal is going to be to try to clear the bacteria, but the ones that had estrogen on board could not clear the bacteria as well. So then just looking a little bit further at what was found on some of this data, just looking at the pictures of the lungs from these mice, these are very microscopic pictures, and it was found that the mice, when they had their hormones entirely knocked out, relative to the mice that got estrogen, there was generally more cells or more inflammatory cells in these mice. And this was just quantified in this bar graph with the amount of inflammation. And these big graphs down here show basically these mice with no hormones, the female mice, and the female mice with estrogen. And when you look at all these different markers, there's these things called TNF-alpha, et cetera. These are all markers of inflammation in different ways. And it turned out that these particular mice had more markers of inflammation, and visually you could see in the lungs that there was more inflammation in these ones that had received estrogen. And really the final piece from this paper was that when they tried to figure out what it was about these mice that they may not be doing as well, they not only concluded that there was more inflammation in the ones treated with estrogen, but they also found that in cells that are a huge part of the immune system called neutrophils in the body, that the neutrophils in both, in the mice, once they were treated with estrogen, and actually they even took neutrophils from from women with CF and treated them with estrogen after the cells had come out, found that when you look at this graph of, again, kind of the amount of Pseudomonas over time with estrogen treatments, that there was more, meaning the neutrophils weren't able to kill the Pseudomonas as well. And they found this when they took out neutrophils from just the blood samples, blood sample donations from women with CF who may have been anywhere in their cycles, but they treated them with estrogen to try to overwhelm the amount of estrogen that was in their normal circulation. And they gave them this and found that more Pseudomonas existed, meaning neutrophils could not kill the Pseudomonas as well. And that actually improved when you gave them this blocker of estrogen receptors. So the big conclusion from this particular work was more inflammation in the setting of estrogen and maybe not as good neutrophil ability to defend the immune system. All right, so I'm just going to briefly tell you about one study that our group is doing based on some of this literature that's out there, and we don't yet have results. We've actually been working on this study for quite a long time, but are hoping to get this out in the next year or so. And this is actually just a trial that we're doing at our own site where we're recruiting women with CF who are in their reproductive years and having regular cycles and having them come in at different points in their cycles. And when you look at this graph on the bottom, we're having them come in at their menses when, again, their estrogen and progesterone would be at the lowest, right near ovulation when their estrogen would be the highest, and then in their luteal phase when progesterone's at its highest. And this is in women not on any hormone contraceptive therapy at all. And we really focused on recruiting women who happen to not be on any hormone contraceptive therapy because we didn't want people to have to come off for our study. And then if they wanted to or are willing, we started them on a hormone contraceptive therapy called Loestrin, which is a combination of a low-dose estrogen progesterone therapy to try to measure then that once their hormones became leveled on these therapies, and we again have them come in, could we determine whether this did anything to improve health, for example? And the different measures that we're looking at in this study are we're measuring lung function on these different visits, we're measuring symptoms using a validated questionnaire, we're collecting sputum and sending this sputum off for inflammatory markers, for density of bacteria, for neutrophil counts, and we're actually even collecting sweat to see if this might change at these different points. And I think as of right now, we have about 20 women who've done the first part of this study, where we've collected them in these 3 phases, and we have a little less than 10 who've gone on to the hormone contraceptive therapy. And then we're also recruiting, just as controls, men with CF, where we've tried to find age and lung function matched men to just compare levels of inflammation in the sputum and these different things. And I'll just very quickly tell you our very preliminary results, and this is not at all finalized because this is when we had a much smaller number of people, but just showing you in the beginning, I'll tell you first off, good news number 1 was that the hormones overall in the women we've looked at so far were where we expected them to be. There are obviously some women with some slight fluctuations, but estrogen and progesterone, and we even looked at testosterone, we looked at LH and FSH, these are all female sex hormones, were in good overall what would match the general population. So the good news is hormones are not generally different in women with CF than they are with men, but there's always exceptions. And when we just started to look at lung function over here on the right, you can see that we actually saw a little bit of a trend towards lung function being slightly lower at the point of ovulation, where estrogen would be its highest. We also have seen a little bit of a trend for lung function to be a little bit higher on the women that went on to hormone therapy, in this case, Loestrin. And actually, you know, interestingly, when we looked at symptom scores, actually, so the lower the score, the worse someone's feeling, we actually found that symptoms actually reported quite a big difference of women that when they were ovulating, symptoms were a little bit worse, especially relative to when they went on hormone contraceptive therapy. Now, none of this is statistically different yet, and that's also largely due to the fact that there's small numbers on any of this, but it's an interesting trend that basically matches that group out of Ireland, where we're seeing that something about the estrogen peak, which is the point of ovulation, may be a point where people aren't doing as well. The other thing this shows is when we've looked at some of the sputum samples, just comparing women versus men, and in particular women when they're ovulating, so that highest estrogen point to men, we actually found a pretty big difference in some of the inflammatory markers where women, again, have much more inflammation than age and lung function. But this is all very preliminary data, so we're hoping that we can have a little bit of good controlled information in the next year or two. But I'll tell you just anecdotally, in what my own patients tell me, I think there is going to be a lot of variation where some women feel worse during their cycle, some people worse during ovulation, some people worse during pre-menses. So it's going to be a tough thing to nail down, but I think at least if we have a little bit of science behind it, then we can start thinking about what we could do in terms of treatment and therapies and how this may help people. So another piece that we're doing, and I'm about to move into pregnancy a little bit, is we're also looking at pregnancy in the same regard. So I think this comes up, of course, on how does pregnancy impact CF? This is another area where overall we don't have a lot of data, but the data we do have at least is fairly good. So this graph here is actually just in general a reminder of what hormones do in pregnancy. So in the 9 to 10 months when women are pregnant, you can see the blue line here represents estrogen, which steadily rises over the 3 trimesters of pregnancy, and progesterone in particular significantly rises over the 3 trimesters of pregnancy. And I think in very wonderful news, the number of pregnancies in women with CF have been on the rise over the last many years. So in the U.S. report, there was about 209 pregnancies reported in the National Registry in 2011, and already 5 years later, that number went up by 60. So it went up to 270 in 2016, and the anticipation is that this is going to continue to rise over time, and wonderfully as women are doing better and really able to tolerate pregnancies. And so it's a very important topic to study to make sure that this isn't adversely impacting anyone's health. So the one probably best piece of literature out there on the impact of pregnancy in the outcomes of women with CF was again done by using the National Patient Registry data from the CF Foundation. And this is an older study, but when they looked at this data, which included over 8,000 women over I think it was about a 12-year period, and they looked at long-term just the impact of those women who'd been pregnant at some point in their life versus those that had not been pregnant over some time in their life, and looked at whether or not there was any difference on survival. It was very slight, but in fact it favored, interestingly, women that had been pregnant, where there was a slight longer or better outcome in the women who'd been pregnant than not. But I'll tell you that there is a little bit of skew in this data on at this time in particular, many of the women who chose to get pregnant during this time window of life, which is in the 1980s and 1990s, tended to have better health at baseline than some of the women who chose not to get pregnant. So that may have skewed this data just a little bit, but overall it was felt that still both groups did reasonably well without a huge impact on health, but for sure not a negative impact from being pregnant. So we too are doing another study similar to what I told you about, trying to look at women in their first, second, and third trimester of pregnancy and just collect data that's not at all going to impact mom or baby, just looking at things like inflammatory markers, PFTs, and sweat tests, et cetera, across the 3 trimesters to see if in a single woman over time, there's some differences that occur. I think it's really hard to use FEV1 as a judgment because, as you all know, when the belly gets bigger, sometimes that impacts lung function. But if we can understand whether or not something else like inflammation or different things are changing, that may help understand the impact of pregnancy. Moving a little bit into menopause here, I'll tell you that we have very, very little data on menopause. And I think this is going to be doing tons better. This is a very important topic to study. In case people don't know the exact definition of menopause, this is really defined in general as the time at which a woman has gone without their cycle for over 12 months and the ovaries overall have stopped producing appropriate amounts of sex hormones. In general, in the United States, for the general population, the average age of menopause is 51, so this can vary tremendously, but there is really absolutely no data in CF yet to understand whether the timing of menopause in CF is the same or different than the general population. What few things are known, and it's not necessarily unique to CF yet, is that menopause is a time of accelerated bone loss. So there is a big and risk for osteoporosis that's known not only in the general population, but also in CF. And there has been some data, good data, even in the general population to suggest that sex hormones impact that. And in this circumstance, estrogen is thought to be good. It's actually important and essential for bone growth. And it's been shown in some literature that progestins or progesterone family medicines that have taken it too long, for example, hormone contraceptives that only have progesterone, and these may include things like Depo-Provera, that for women who've been on these for too many years, and they usually say over 3 to 5 years, that this is at least can be associated with more rapid bone loss or an increased risk for osteoporosis. But outside of this literature, really we have very limited literature of any kind on menopause in CF. So I think this is an incredibly important topic to study. Okay, and then I just wanted to hit a few unique topics because I think this hits home to many people, and I know I've had many patients struggle with this, and unfortunately I'm stuck with not knowing what to tell people. But there are many, I think there's a number of women out there who report hemoptysis, meaning coughing up blood at different points in their cycle that has not been well understood. And this, again, is something that is not well studied, but I'll tell you the little bit of information that's out there is this is thought to be a process called catamenial hemoptysis. And this is just a medical term for women having cyclical variation in coughing up blood. And this is really thought to be due to people having some endometrial, that meaning some type of uterine tissue in the lungs. And I'm sure many of you guys have heard of endometriosis, which we often think of as that residual uterine tissue in the abdominal cavity somewhere that can cause women pain. The same type of process where this tissue can exist in different parts of the lungs can occur. This is incredibly rare, and this is only one explanation of why this cyclical variation in coughing up blood may occur. And this, again, is not unique to CF. This is something that can occur in the general population as well, but it has been in different circumstances where people have tried treating women in this circumstance with hormones, mainly hormone contraceptive therapy of some type to suppress the variation in estrogen and progesterone to see if this will temporize this. Other methods that have been tried is surgery to try to take out the part of the lung that may have this tissue, and other things that have been tried is something called bronchial artery embolization. You guys may have heard of embolization, where they try to actually block the blood vessels that are supplying this area so that people will no longer cough up blood. But in terms of the prevalence of this in CF or what to do or good descriptions of this, it's very, very limited. But I know I have a number of patients who describe this, so I'm sure throughout the country, many of you know others or have maybe even experienced it yourself. Okay, so I think I'm hitting towards the end here, but I just wanted to mention one last set of literature out there about the outcomes of women after a lung transplant, because I think that question comes up often as well. And this was a study actually done using lung transplant data, so not using the CF patient registry data, but using what's called the UNOS database, which is a national database of all people who've undergone lung transplantation in the United States, where people were looked at in a big period of time from 2000 to 2012, and exclusively the ones who had a lung transplant from cystic fibrosis. So the first thing that was looked at is again, the survival, and this is by time after lung transplantation, where 0 over here represents the time at which the lung transplant occurred, and this is about 10 years out from lung transplant, and how men versus women do after lung transplant. Now, I'll tell you the interesting and great news is that there was no difference between men and women found in this study, so that basically the long-term outcome was identical between the two. And this is really interesting because it really makes you wonder, is there, what happens when you get a lung transplant is a lung is put into the body that no longer has CF. Now, of course, the rest of someone's body will still have CF, including the sinuses and everywhere else, but the lungs now have functioning CF channel. So this really kind of lends itself to an interesting question about, by putting in a new set of lungs that no longer have the CF channel, is this what put these women on the same plane, or is it something totally different? We don't know the answer to this yet, but it actually starts pointing to the fact that maybe sex hormones are impacting the actual CF channel, kind of what we talked about earlier in the discussion, but we don't know that. And this was just a look at, depending on if a woman got a man's lung or if they got a woman's lung, or if a male got a female lung or a male lung, would there be a difference? Overall, I'll tell you there was not a huge difference in terms of whether someone received a male lung or a female lung in one particular group doing worse. And the other thing I'll tell you is that overall, when you look at this number here in terms of the outcomes of women and men, it is still such that women were not living as long as men, but they were transplanted earlier. It wasn't that their time after a transplant was different. It was that they actually received their lung transplant at an earlier age because of this issue we face of people not doing as well that are female. Okay, I'm just going to skip through that because it's a lot of details. And so I just want to kind of summarize what we talked about, and that is from what we know, at least from the bench side of preclinical data, whether it's cell data or mouse data, there's been some evidence that estrogen in particular may somehow be impacting immunity or an ability to fight off infections. And I think the most data comes out of Pseudomonas aeruginosa, but we don't know that any of this is unique to Pseudomonas aeruginosa. There's also some evidence that estrogen may be promoting inflammation, or at least being associated with higher levels of inflammation, that it may be associated with a negative impact on the air surface liquid, that's the ASL, and even on ion channel transport on the top of these cells. There's some clinical data out there that there's an association between higher estrogen levels and exacerbations in women with CF, and again, that there's an overlay of Pseudomonas and whether maybe estrogen may be impacting the Pseudomonas converting to this mucoid type of Pseudomonas. And finally, there's evidence that there is a distinct outcome difference in men and women with CF, and that this is occurring before lung transplant, meaning when a CF lung is in place, but not necessarily after a new lung has been put in place after a lung transplant. So that's really the information we know with a lot of gaps in it, and there are a lot of unknowns, and I think the discussion is going to focus on this a lot today, but that is, what is the real impact of hormone contraceptive therapy on health outcomes, both lung outcomes and non-lung outcomes. I focused a lot on lung outcomes today, but I think things such as what's the impact on the GI tract, what's the impact on mental health, what's the impact on everything is also very important. What do we know about menopause, and what can we find out about menopause in terms of the timing in women with CF, and what can we do to ameliorate any of the problems that may occur from menopause? And then again, what are the direct effects of hormones on things such as hemoptysis or coughing up blood, on things such as VTE, which is venous thromboembolism or clots, because there's been some association of hormones with clotting. What's the impact on bone density and osteoporosis? A lot of about estrogen, but we really know very little still about androgens, which are the testosterone category. For all we know, maybe testosterone is helping men, and somehow we need to think about, is there a way that women need to receive a little without all the adverse side effects? And or what do we need to find out about progesterone or even other sex hormones that I didn't get into today? But there's a whole host of information that we don't know. So my goal today was just kind of to walk you through a little bit about what we know about women with CF from childhood to adulthood. It certainly was not exhaustive, but just meant to be really just thought-provoking, I hope. And I'm happy to answer any questions I'm able to, and I hope, I'm excited to hear the discussion today. Thank you.